We described the hepatitis C virus life cycle and looked at the mechanism of action of direct acting antiviral agents. We also looked at recommendations from AASLD IDSA guidelines for genotype 1, 2, and 3. Now the next learning objective is given on Hep C patients, evaluate and manage drug-drug interactions. When it comes to drug interactions, it's important to keep in mind that pretty much majority of antiviral agents used for hepatitis C are substrates of P glycoprotein. Especially sofosbuvir, which is the most commonly used agent, P glycoprotein is a P glycoprotein substrate, as well as ledapisphere, daclitasphere, velpatasvir, and voxilaprevir. In addition, daclitasphere is also a substrate of CYP3A enzyme. Now, while voxilaprevir is also a substrate of CYP3A, daclitasphere is significantly more impacted by CYP3A interactions. In addition, ledapisphere, daclitasphere, and velpatasvir themselves inhibit P glycoprotein. Here are the rest of the agents. You can see that with the exception of glecaprevir and pibrentasvir, which are not substrates of P glycoprotein, the rest of them are substrates of B glycoprotein. So when it comes to drug interactions, it's important to keep in mind that there are drugs that are actually inhibitors of P glycoprotein. So these can affect those Hep C drugs that are substrates of B glycoprotein, as well as there are some inducers of P glycoprotein. Now let's take a look at Harvoni or sofosbuvir ledapisphere. Ledapisphere needs an acidic environment for absorption. Therefore, there are drug interactions when it comes to acid suppressive agents. So antacids should actually be avoided within 4 hours of administering sofosbuvir ledapisphere. Proton pump inhibitors, it's best to avoid it, but if someone has to have it, it's recommended to give it simultaneously. So by the time the PPI kicks in, hopefully ledapisphere has already been absorbed. And it's best to actually give it with food if this interaction is to happen. And H2 receptor antagonists can actually be given simultaneously or separated 12 hours apart. And of course, for most patients with normal renal function, H2 receptor antagonists are actually given every 12 hours. So that makes it impossible to separate by 12 hours. For those patients that require renal adjustment, H2 receptor antagonists are administered once a day. So for those patients, you can actually separate by 12 hours. Also with the PPI, the interaction is dose dependent. So patients who are on higher doses of PPI, so for example, people with recent GI bleed who are on a PPI twice a day, they're more likely to have the interactions because of the stronger acid suppression. Now note that with these drug interactions, some of them are actually contraindications and some of them are actually not a contraindication, they're just not recommended. So for example, rifampin and St. John's wort, they're actually P glycoprotein inducers, and their concomitant use with Harvoni is not recommended, along with some other agents. When it comes to statins, rosuvastatin is not recommended. It's okay to use atorvastatin, which you will most commonly see in practice. And for those patients, you should just monitor for symptoms of myopathy. Now, when it comes to amiodarone, there's been a drug interaction specifically with sofosbuvir. So there's been serious symptomatic bradycardia case reports, including fatality. So because of that, it's very important to monitor patients who are on amiodarone. It's best to avoid it. But if, if someone absolutely needs to have amiodarone, it's best to explore options that do not require sofosbuvir. But again, this is not a contraindication. So if the patient does need to be on both of these agents, then it's important to have regular cardiac monitoring in these patients. With the Vicera pack, because it's a boosted regimen with ritonavir, there are many drug interactions. In fact, there are a few that are contraindicated. So these three statins are actually substrates of CYP3A enzyme. So because ritonavir is a strong CYP3A inhibitor, they're actually contraindicated. And because of this pharmacokinetic booster, there are many more interactions that are listed in the package insert. So I refer you to the package insert. Daclitasphere also has contraindications with strong CYP3A inducers. And of course, the dosing of daclitasphere is also dependent on some of these drug interactions. And because this combination has sofosbuvir, amiodarone interaction also exists. With Zapatir or Elbasvir, Grazoprevir, strong CYP3A inducers are actually contraindicated, along with some HIV regimens that we will discuss later. With Velpatasvir, it also requires an acidic environment for absorption, so the same recommendations that apply to Ledipasvir also apply to Velpatasvir. And of course, amiodarone interacts with sofosbuvir. When we have Vosevi, basically it has the two agents from Epclusa and it just adds voxilaprevir to it. So all interactions from Epclusa apply to Vosevi plus more. So voxilaprevir is a protease inhibitor. So rifampin is a strong inducer of CYP3A and is actually contraindicated. For Maviret, rifampin is contraindicated. Etazanavir is a HIV protease inhibitor, and that one specifically is contraindicated, whereas other HIV protease inhibitors are just not recommended. And one interaction that exists with all direct-acting antiviral agents is the warfarin. So because all of them can affect warfarin, it's recommended to increase the frequency of INR monitoring. So that one is basically just managed by adjusting the dose of warfarin based on INR.